With this, we move on to the third scientific session today, and Dr. Mridul Bera would speak on the topic, the thiazide-like diuretic drug Chlorthalidone in diabetic hypertensive patient. I would like to invite Dr. Mridul Bera, who is a cardio-diabetes physician with many years of expertise, and he is attached to Narayana Super Speciality Hospital, and he is also the founder member and treasurer of Howrah Town Diabetes Study Society. To chair this particular session, I would like to invite Dr. Sanjay Shah, who is an endocrinologist and diabetologist and founder member and president of Howrah Town Diabetes Study Society. Along with him, Dr. Ambarish Bhattacharya, who is a physician, doctor, and has areas of interest in diabetes, gastroenterology, and rheumatology. Dr. Ipshita Ghosh, ma'am, who is a consultant endocrinologist.
It gives me great pleasure to call on stage Dr. Mridul Bera to start his deliberation.
Good morning to all of you. So, after the two diabetic topic, I also speak on the diabetic, but a little bit different. I'm just talking about the role of chlorthalidone in diabetic hypertensives. Now, if you can think about why I'm choosing these topics, so this is a very interesting one, because when you just treat an hypertensive patient, always there has been some concern whether we can use the chlorthalidone or not, because there are some adverse effects. Now, my job is to just clear the doubts whether the chlorthalidone can be used an effective agent for a diabetic hypertensive patient. Now, talking about the diabetic prevalence, if you can see the huge prevalence we have got all over the world, 537 million people have been suffering from diabetes. This is according to the 2021 data, and every 3 in 4 adults have been suffering from diabetes. And if you can think about the diabetic capital of the world, India is not lagging behind. In Southeast Asian population, almost 90 million people has been suffering from diabetes, and almost 75 million there among the Indians. Now, not only diabetes, if you can think about the hypertension prevalence is very, very high in Indian population. If you can see the ICMR India B study 17-2023, if you can see the hypertensive population in India is around 315 millions. And if you can think about the diabetic population in 2023 by the ICMR data, 101 million people, the Indian patient, have been suffering from diabetes. Not only diabetes, if you think about the pre-diabetes, almost 136 million people have been suffering from diabetes, and if you just add it, the diabetes and pre-diabetes, almost 240 million people have been suffering from the diabetes or the pre-diabetes. Now, among all the other non-communicable disease, very, very rampant in India as well. Now, talking about the link, the hypertension and diabetes, they are pathologically intertwined. Now, in India, the most prevalent, the comorbid condition in hypertension or in diabetes is definitely the hypertension. Almost 62.3% patients of diabetes have been associated with an hypertension. Now, the diabetes and hypertension, you can think about a double jeopardy. Almost the common risk factors has been there in both the diabetes and hypertensive, with the genes, with the insulin resistance, with the dyslipidemia, with the obesity. The diabetes and hypertension, they can produce as the atherosclerosis, lot of endothelial dysfunction, there will be a lot of vascular inflammation, there will be the vascular fibrosis, arterial remodeling, all lead to the different type of micro and the macrovascular complication and leading to the cardiovascular disease. So you can say, if you have the diabetes and if you have the hypertension, it is combined, the double jeopardy will occur and there is the more chance of developing the cardiovascular disease. Now the thing is that occurrence of hypertension in patients with diabetes is more common. There is more chance of, you can say, the developing an hypertension comparing the occurring of hypertension in patients without diabetes. Now, if you can see the prevalence of hypertension at the onset of diabetes, quite high, 39%. And if you can think about the relative risk of hypertension in diabetic population compared with the non-diabetic population, just think about 4.7 to 7.7, almost the 7 times higher risk of developing hypertension in a patient who have diabetes rather than the non-diabetic. So hypertension and diabetes may be present at the time of initial diagnosis, or you can say the hypertension may precede the onset of diabetes mellitus. Now think about this, the diabetes approximately doubles the cardiovascular risk in patients with the hypertension. Do we need any reference? Yes, I am just giving you some of the reference. This is the SAFE study where the patient with the diabetes, and if you compare with the patient without diabetes, you can say that there is more chance of the increased incidence of the cardiovascular event, stroke, and the coronary heart disease events. Talking about the systolic, the European study, the systolic hypertension Euro study, the same thing happening. The patient with the diabetes having more chance of developing the cardiovascular event, stroke, and the coronary heart disease event compared to the patient without diabetes. Also, in the HOT study, we are finding the same. So always, if the patient is having hypertension with diabetes, there is the more risk compared to the patient without diabetes. Now, how we can treat the patient of diabetes with an antihypertensive drugs? Now, talking about the diabetic management, particularly if the patient is associated with hypertension and diabetes, the three key figures is this, that we have to aggressively manage the type of diabetic hypertensive patients. The first, definitely the A, we have to reduce the HbA1c level to less than 7%. The B, we have to reduce the blood pressure. The recent guidelines say you have to lower it by 130 by 80. And talking about the cholesterol management also, you have to reduce the LDL cholesterol, not only less than 100, but I think it should be less than 70. Now, what is the benefits of diabetes? By controlling the ABC. You can see the amount of the benefit you can say the gain about the controlling the ABC. Intensive glucose control reduces the risk of AD cardiovascular disease by 42%. Blood pressure control even further, it can reduce the cardiovascular disease by 32 to 50%. And if you go for the diabetic, the cholesterol control, it can reduce the cardiovascular events by 20 to 50%. So not only the blood pressure control, we have to aggressively control the blood glucose and as well as the lipids. Now think about it. What is your target level? How low you can go? Now thing is that the different guidelines say the different thing. But I think that less than 130 by 80 is the current target you can choose. Now this is rather you can say the practical. Now if the patient is having hypertension and the patient is having any of the risk factors like non-ASCVD, the patient is having heart failure, patient is having diabetes mellitus, patient having chronic kidney disease, patient age of more than 65 years old, or the ASCVD risk score of more than 10%, I think your target level of blood pressure, particularly I am talking about the office blood pressure, it should be systolic around 125 by 30 and diastolic should be less than 80. Now, if the patient do not have any of the risk factor, you can lower it, but again the systolic should be around 130 to 140 and the diastolic should be less than 90. So any risk factor, hypertension associated with any risk factor, you have to lower it by 130 by 80. Now, what is the benefit of blood pressure control in diabetes? I think you have to definitely understand that the amount of benefit we can get with the lowering of the blood pressure. I am just giving you example. Each 10 millimeter drop in systolic blood pressure, you can say there is the reduced incidence of 12% risk of all-cause mortality, there will be the 12% risk of heart failure, reduced incidence of fatal and non-fatal MI, 19% risk of fatal and non-fatal stroke, 12% risk of any endpoint related to diabetes, and definitely there is reduced incidence of diabetes related to the death related to diabetes. Now, talking about the how low you can go. Now, I'm not talking about the how low you can go, but this is a study that you can understand if your diastolic blood pressure of less than 90, or if you can compare with the less than 80, I think the lesser CV events in patients with the diabetes in the lower BP goal that has been shown in the HOT study. Now, if you can see, if you lower the blood pressure, diastolic blood pressure of less than 80, there is the least incidence of myocardial infarction, cardiovascular death compared to the if you lower the diastolic blood pressure of less than 90. Now the thing is that the controlling blood pressure is definitely crucial, but the question is all the antihypertensive are the same or not? Now, if you can see the recent, you can say the ESC, the guidelines, they have said that you have to start with the dual combination therapy in most of the situation, sparing some of the situations where the patient is having stage 1 hypertension, patient is having frail, or the patient is having ASCVD risk factor very high, but the patient is having high normal BP. So in that case, you have to start with the monotherapy. Otherwise, you have to start the patient with the dual combination therapy. And dual combination therapy, they have said, we have to start with the ACE inhibitor or ARB plus calcium channel blocker or the diuretics. Now, which diuretic? They have preferred that we have to start the patient with the thiazide or thiazide-like diuretic. And if the pressure is not controlled, then you can add the other drugs. Now, the recent update is that the beta blocker, it can be used as a monotherapy or any step in the combination therapy. Now, if you can look at the American Diabetic Association recommendation of the hypertensive management, they are on the same line. That if the patient is having stage 1 hypertension, we have to start with the single drug, and you have to, if the patient is having the secondary, the stage 2 hypertension, you have to start with the dual agent. But the thing they have said, if the patient, we have to start the single agent or the dual agent, you have to consider whether the patient is having albuminuria or the coronary artery disease. If the patient is having albuminuria or coronary artery disease, your agent should contain either ACE inhibitor or ARB. And if not that, you can start with the other agent. For the dual combination therapy, the same thing. If the patient is having albuminuria CAD, you have to start with the ACE inhibitor or ARB containing therapy. But the second drug they have chose about the diuretic therapy, they have said the thiazide-like diuretic, long-acting agents, because you know that the thiazide-like diuretic, chlorthalidone and indapamide, they are the long-acting agents. They are the thiazide-like diuretic long-acting agents shown to reduce the cardiovascular events such as chlorthalidone and indapamide are preferred. So according to the ADA, the thiazide-like diuretic like chlorthalidone has been the preferred one. Now talking about the comparison, I am talking about the chlorthalidone, but the thing is that you have to compare whether it is beneficial to the other comparative agents. So here the meta-analysis of the 42 randomized control trial showing that the low-dose diuretic when it is compared to the placebo in every aspect, in lowering of the cardiovascular disease, congestive heart failure, stroke, CAD event, it has been far better. Now when it is compared to the low-dose diuretic like the chlorthalidone and compared to the beta blocker, in some of the aspects, reducing the cardiovascular disease, congestive heart failure, it has been far more better. Low-dose diuretic versus ACE inhibitor. Not only in the congestive heart failure and the stroke incidence has been much lower in the low-dose diuretic compared to the ACE inhibitor. The important thing is the low-dose diuretic when is compared to the calcium channel blocker, again there is a less incidence of congestive heart failure and the coronary heart disease compared to the calcium channel blocker. So this is another trial you can say that this is the antihypertensive and lipid lowering treatment to prevent heart attack trial. This is called the ALHA trial. Again, just you have to remind, I have to remind you that ALHA trial, the included population is the elderly population, more than 55 years old. So here more than 42,000 patients was selected, and this patient was given the different antihypertensive drug. Chlorthalidone has been the most, you can say the most preferred one, and also the amlodipine, lisinopril, and doxorubicin. The study lasted for 8 years, but this study was definitely has been discontinued for increased incidence of cardiovascular events. Now look at this. The effect on systolic blood pressure reduction in chlorthalidone arm, 12.3 milligram, and it has been the highest compared to the amlodipine and the lisinopril, where the reduction of the blood pressure is around 11.5 milligram, showing its effectiveness in reduction of the systolic blood pressure. Now what is the effect? Now if we choose the antihypertensive monotherapy like chlorthalidone, when it has been compared to the amlodipine and lisinopril, in terms of the cardiovascular event, they are more or less same. So the choice of antihypertensive drug according to the cardiovascular effect, there is nothing comparable. But the thing is that in prediction of the heart failure, you can see in the ALHA trial what has been seen, the chlorthalidone group showing the least incidence of heart failure compared to the amlodipine and the lisinopril. What about the risk of stroke? Again, this showing the amlodipine is the best one for the reduction of the stroke risk, but the chlorthalidone is the second one and the least effect that has been seen with the lisinopril. Again, the showing chlorthalidone has been a good agent for reduction of the stroke in the ALA trial. What about the diabetic and non-diabetic population? Particularly in the ALA trial, we have been showing that in the prevention of the heart failure, the chlorthalidone has been far better compared to the amlodipine. So that, if you can see, in a heart failure population, particularly the JACC has published a paper where they have said the diabetic hypertension and diastolic dysfunction, that is, we call it the heart failure with the preserved ejection fraction. In conclusion, they say, in diabetic hypertensive patients with diastolic dysfunction, thiazide-like diuretics should be preferred ahead of calcium channel blocker for the blood pressure control. Now look at the SAFE trial. Again, this trial was tried in the elderly population, the systolic hypertension in the elderly population, that is the SAFE trial. Again, you can see the benefits of the chlorthalidone, 36% reduction of the total stroke, and also the major cardiovascular events also been reduced with the use of chlorthalidone. Now, in the original paper, in the original study, SAFE was a 5-year study. Now, the study when has been followed up, this is a 14 years follow-up. What has been seen, the chlorthalidone group, you can see the long-term effect of the diuretic-based therapy on the fatal outcome in subject with isolated systolic hypertension, even after the follow-up, that is even after 14 years follow-up, the chlorthalidone group showing the greater reduction of the CV mortality compared to the placebo, that is 15% reduction of the cardiovascular mortality has been seen in the chlorthalidone arm. Now think about this. The new onset diabetes. Always we have to thinking about the new onset diabetes associated with the thiazide or thiazide-like diuretic. Now if you can see the SAFE trial, yes, there is increased incidence of diabetes in the thiazide-like diabetes in the chlorthalidone group. So number of subjects developed the diabetes 258, and number of subjects developed diabetes in the placebo group 169. I agree that there is more incidence of diabetes, but if we can think, there is no impact on the cardiovascular mortality and the total mortality. If you can see, the cardiovascular mortality in chlorthalidone is 1.05 compared to the CV mortality in the placebo 1.56. Total mortality 1.15 in chlorthalidone, but again the subject on placebo 1.35. So there is no impact on diabetes, new onset diabetes, on cardiovascular mortality and total mortality that has been seen in the SAFE trial. Another trial, if you can see, the multiple risk factor intervention trial, that is we call the MRFI trial, where the hypertensive population was given the hydrochlorothiazide chlorthalidone. So that now I am just seeing what is the difference between these two groups, that is the thiazide and thiazide-like diuretic, hydrochlorothiazide and chlorthalidone. This is MRFI trial, systolic blood pressure reduction. You can think the systolic blood pressure reduction is more in the CTD group compared to the hydrochlorothiazide. So it has been more effective compared to the hydrochlorothiazide. What about blood sugar level? Again, the hydrochlorothiazide group showing the more hyperglycemia compared to the CTD. So in terms of effectiveness, it has been better compared to the hydrochlorothiazide. In terms of adverse effect, the hyperglycemia production, it has been less compared to the hydrochlorothiazide. So what is the guideline recommendation of this chlorthalidone? So this is our joint recommendation by the API and the Indian College of Physicians. They said the two diuretics that is the most frequently used to study to treat hypertension in diabetic patients are chlorthalidone and indamamide. Both are thiazide-like long diuretic. For older non-insulin treated patients with type 2 diabetes and isolated cystic hypertension, this has been preferred. Chlorthalidone has demonstrated the similar benefit as compared to the ACE inhibitor and the CCB. Low-dose chlorthalidone decreased the rate of major cardiovascular events by 34%, all-cause mortality by 13%, and total stroke by 36%. And the last thing is important. Due to the possibility of raising blood glucose levels and HbA1c, diuretics like hydrochlorothiazide, that is, the thiazide diuretic, are not advised for use in people with diabetic hypertension. They have mentioned it. Hydrochlorothiazide has not been preferred. What about the international recommendation? If you can see the ACC recommendation, they said in the adults with diabetes and hypertension, all first-line classes of antihypertensive agent can be preferred, that is the diuretic. They have mentioned it, that either thiazide or thiazide diuretic, ACE inhibitor, ARB, and the calcium channel blocker. They have given the class 1A recommendation. So this is the recent guideline. This is the ESC recent guideline. They say among all BP lowering agents, AC inhibitor, ARBs, dihydropyridine calcium channel blocker, diuretics, they specially mentioned thiazide and thiazide-like drugs such as chlorthalidone and indapamide have demonstrated the most effective reduction of BP and cardiovascular disease events, and therefore recommended as the first-line treatment to lower blood pressure. They have given it the class 1A recommendation to chlorthalidone.
Dr. Bera, 2 minutes to go, please. Thank you.
Now, if you can see the RSSDI guideline for the management of hypertension in patients, they also preferred the low-dose thiazide like the chlorthalidone and over compared to the other agents. And also they have mentioned the diuretics such as hydrochlorothiazide are not recommended in patients with diabetic hypertension because of its potential to elevate the fasting blood glucose level and A1C level. I need 1 minute. Now, if you can see the CLIC study, whether this chlorthalidone can be used in an advanced CKD population. This is an interesting one. All the patients are included, that is the CKD stage 4, where eGFR of less than 30. Chlorthalidone has been used as on top of the standard of care. You can see the reduction of blood pressure compared to the placebo, that is 10.5 milliliter more reduction of blood pressure. USCR reduction, 50% reduction, that is 52% more reduction. But the thing is, they are not going to improve there is some indication that it increases the creatinine. But on effectiveness, it has been comparable to other agents. Now, what is the adverse effect? Now, if you can see the adverse effect of the chlorthalidone, there are some responder to chlorthalidone and some non-responder to chlorthalidone. Now, who will respond and who will not respond depending on the things. Then in non-responder group, what has been seen, there is a reduction of blood pressure in the blood balloon that increases the angiotensin level in some of the non-responders. That increases the resistance. So that group of patients will not respond to the chlorthalidone. What is the adverse effect? You all know hypokalemia, hyponatremia, hypomagnesemia, hyperuricemia, photosensitization, and there is the development of skin cancer. Now, talking about the adverse effect, there is some difference between the hydrochlorothiazide and chlorthalidone. More incidence of hyponatremia occurring in chlorthalidone group, 1.31 more hypokalemia and the acute renal more in the chlorthalidone. But you have to use the chlorthalidone in a low-dose therapy. So, in conclusion, what I can see, thiazide and thiazide type diuretic like chlorthalidone are the first-line antihypertensive drug in both diabetic and non-diabetic population with hypertension. Among diuretic, chlorthalidone is the choice of drugs for hypertension control and severe outcome in patients with and without diabetes. And chlorthalidone has got more beneficial effect in preventing the heart failure in diabetes. So this is my last slide. I will end here. But again, just remind you, we demand justice for our. Thank you.
Right, any questions from the floor? Thank you, Dr. Bera, for that lovely, yeah, please.
Hello, good morning. Thanks for your Mavin speech. My first question is that many of the diabetic patients, particularly elderly, they're the victims of autonomic dysfunction like postural hypertensions. So what's your comment that what should be the safe drug for these elderly patients for postural hypertension? Will it be still this chlorthalidone or some ARB? And second question is, the market is flooded with this midodrine. So what's your comment on midodrine? Well,
now, regarding your first question regarding the postural hypertension that has been occurring in the elderly population, I think there is no contraindications that you cannot use it in the patient, in the elderly patient, because if you see the ALHA trial and the SAFE trial, that was done both in the elderly population where the minimum age, that is the average is more than 60 or 55. So I think, yes, if the patient is having hypertension, if you can use it, the low dose chlorthalidone, I think that you can use it. And the second question is about the use of midodrine. Yes, we are definitely giving the midodrine to the patient who is having the postural hypertension, but I think any population who are hypertensive and we are giving the antihypertensive drug, rather than giving midodrine, if you just choose your antihypertensive drug effectively, and I think that there is no need of using the midodrine, particularly the patient on antihypertensive drugs.
Chlorthalidone, you should not use beyond GFR of 25 because there its effectiveness reduces. Secondly, beyond 25.
Okay.
they have to choose other diuretics. Secondly, I'll just ask two questions. One is, what are the follow-up investigations you need to do a patient who is on chlorthalidone? Number one. Number two, does it has any role in renal calculus disease, which type, and what it causes to the serum calcium levels?
So the thing is that if you can seeing the click study, the CKD population was selected, that is the patient was stage 4 CKD, where the patient EGFR of less than 30, that has been selected in the click trial, and that has been showing the good effectiveness in terms of the reduction of the blood pressure and reduction of the UACR. Only thing, there is no improvement in the creatinine, rather there is an increase in the creatinine level. So in terms of effectiveness, I think it has been at par, or it has been somewhat better if you just use this judiciously. And talking about the investigation, we often need, and because if you can see in our climate, that is a hot and humid climate, always we are just sweating. So if the patient is having chlorthalidone, I do not use the high dose chlorthalidone, particularly the elderly population. I use the low dose chlorthalidone, because if you can see the AHA trial, and if you get the SAFE trial, in the CLIC trial, they have used the chlorthalidone in the higher doses, up to 50 milligram dose they have given. But in our situation, I think in an elderly population of more than 60, I will not use it beyond 6.25 milligram. And in that case, I will always check what is the electrolyte level, sodium level, potassium level, magnesium level, and I use it regularly. If the patient is any indication that the patient is going to develop the hyponatremia, I will definitely avoid it.
Most of our diabetic patients, they require 2 to 3 classes of drug to control blood pressure, like calcium channel blocker, ARB, and diuretic. But if suppose blood pressure is stage 1, and we think that only one drug will be effective, so which will you choose first, whether ARB or whether diuretic?
No, actually, if the patient is having on the stage 1 hypertension, if you have to choose the one drug, I will definitely go for the either RAS blocker, either ACE inhibitor, ARB, or the calcium channel blocker. My take is the patient is a young one, so like that there was the older guidelines, the NICE has said if the patient is having the on stage 1 hypertension, you have to choose the drug. If the patient age is around less than 55, I have to go for the ACE inhibitor or ARB rather than calcium channel blocker. And if the patient is age of more than 50 or 55, I will choose the calcium channel blocker. But I will not go with this only this low dose thyroid diuretic like the chlorthalidone. If you have to choose the one drug.
Thank you very much, Dr. Bera. I think all good things must come to an end. Thank you.
Thank you.
Thank you, Speaker, sir. I would like to request the chairpersons to felicitate our speaker today. Sir, I welcome you back on stage for the felicitation. I would like to invite Dr. S.K. Somani to felicitate Dr. Ambarish Bhattacharya. Sir, I would like to invite you back on stage. Thank you, Dr. Somani. Thank you, Dr. Sanjay Shah. Thank you, Dr. Bhattacharya. With